Now, for some conditions in a patho class, I don't go much beyond basic pathology, but since diabetes is such a massive, massive part of clinical practice for all of us, you really need to know diabetes inside, outside, upside down. And you need to hear it a couple different times in a couple different classes. So we're going to go a little bit deeper into it than we do with some of our smaller pathologies. Here I have some blood glucose numbers that you're going to probably need to commit to memory, if not now, sometime soon. Largely because you're going to be looking at people's blood glucose for the rest of your life. So knowing some of these numbers is really, really helpful. Two numbers that I find especially important are that fasting glucose of 126 or higher and the glycated hemoglobin, or hemoglobin A1C as it's called, of 6.5 or higher. These are two numbers you're going to see a million times over, so really is a good idea to start kind of cementing them in. Now, hemoglobin A1C, glycated hemoglobin, that's kind of always one of those things where people go, I'm not really too sure what that is. Try to think about it this way. With all the extra sugar floating around in the vasculature, in the blood, red blood cells actually start to soak up excess glucose in a process called glycation. Patients who have, on average, higher amounts of glucose in their blood have red blood cells that show more glycation occurring. Since a red blood cell lives between 3 to 4 months, your glycated hemoglobin level, also known as hemoglobin A1C, is a reflection of average glycemia over the preceding 3 months. It's the most commonly used blood value when you are managing and working with these patients, which you will be doing long term. What glycated hemoglobin does not tell you are the peaks and the troughs, the ups and the downs, the highs and the lows. It's just an average. To accurately categorize a type 1 diabetic into type 1A or type 1B, autoantibody testing has to be done. For type 2 diabetes, you may see a blood measure called C-peptide performed. C-peptide is a reflection of how much insulin is actually being produced in a patient's body with type 2 diabetes. One of the reasons that C-peptide is measured and used as a reflection of insulin production in the body is that it's a byproduct of natural insulin production. You might say, hey, couldn't we just draw blood for insulin levels and measure insulin levels? That would be nice, but when these people are coming into the healthcare setting and they're hyperglycemic, it's relatively frequent that they're getting exogenous insulin as well, making a blood value for insulin a little bit less diagnostically authentic. C-peptide, the byproduct of insulin production, is considered to be more accurately reflective of what's actually going on in the pancreas. You're going to learn a lot about diabetic meds and the cocktails that diabetics will take medicinally to help control blood glucose. My goal for my class is to learn about 3 variables that must stay in balance such that glycemic control can be maintained and things aren't too high or too low. Those 3 variables are a person's diet. How much carbohydrate are they taking in with their meals? How much exercise are they doing to utilize those carbohydrates? And the third variable is what medicines are they taking to manipulate things and keep them within a normal therapeutic range. When it comes to diet, one of the things you're going to hear and you're going to work with patients, especially those of you that work in primary care, you are going to instruct them about glycemic index. If you're referring them to a dietitian, the dietitian is going to talk about glycemic index. And the basic definition of glycemic index is when I eat a carbohydrate, goes down the esophagus into my stomach, small intestine, how quickly do the carbohydrates get absorbed from the gut to the bloodstream? A food with a high glycemic index is quickly absorbed and quickly spikes blood sugar. A food with a low glycemic index is more slowly absorbed, does not spike blood sugar, and is generally considered to be a little bit more of a manageable carbohydrate for patients on diabetic restricted diets. Regarding the variable exercise, please let your patients with type 2 diabetes know that research has shown exercise can help reduce insulin resistance and resensitize body tissues to insulin. One of the things that you'll see when you work with diabetic patients is a blood sugar diary. Because hemoglobin A1C doesn't tell you the highs and the lows, it's necessary for patients to keep a blood sugar diary and to bring it into their clinical environment. So whether you are working primary care and managing diabetics there, working in endocrinology specifically and managing tons of diabetics there, the blood sugar diary is your real way to help estimate how well the therapeutics are working for your patients. A lot of cool ways to do blood glucose diary. Pencil, paper, fancy charts, stuff that the patients print off the internet. Almost every glucometer I've seen in the last 10 years has a little button where you push back and can look historically back at the date and time the blood glucose was taken. Lots of different ways to do it. Now, diabetes by itself, it's hyperglycemia. What's the big deal? Well, the pathology that is diabetes mellitus leads to so many other pathologies as well, very complicating pathologies. The most important word in this picture is the word angiopathy. Hyperglycemia promotes angiopathy, and this goes right back to that whole process of accelerated atherosclerosis. Where in your body does not have a blood vessel that is susceptible to this process? If you're scratching your head and going, I've got blood vessels everywhere, you're absolutely right. Your diabetic patients have blood vessels everywhere. They are at risk for angiopathy everywhere. And that's why when you look at these long-term complications and you see this massive list, it's because blood vessels are everywhere. In addition to angiopathy, hyperglycemia and hypoglycemia can lead to some fairly dire circumstances. Hyperglycemia can lead to diabetic ketoacidosis or hyperosmolar hyperglycemic non-ketotic syndrome in your type 2 diabetics. Hypoglycemia is no good either. Hypoglycemia can lead to diabetic coma and death. Now, hypoglycemia is a potential serious complication of diabetes mellitus. And when we're first learning about this, it's easy to say, how can these people be hypoglycemic when the disease is a hyperglycemic disease? Dig the three variables: the carbohydrates or the diet, the exercise, and the meds. If one of those three variables isn't balanced or is excessive, what you could be doing then is driving blood sugar too low. So let's take the I guess, most obvious example of a type 2 diabetic patient, well managed on meds, takes in the same amount of carbs every day, but wants to really get back in shape and does one of those kind of internet fad exercise things. Doesn't tell anybody, doesn't change how many carbohydrates the person eats, takes the same meds, and then goes and exercises like crazy. And a one, and a two, and a one, and a two, and a one, and a two. So that exercise variable is ramped up. Glucose utilization is ramped up, and we have a scenario where blood glucose could fall significantly. Here's another scenario. A patient normally well controlled through their three variables, their diet, exercise, and meds, is going for, say, a small minor outpatient surgical procedure. And the patient is advised to not eat or drink anything after midnight, including the morning of the surgery. Forgets to ask about diabetic meds, takes the meds with water because it's part of the routine. So there you have a setting in which the meds are in, but there's no carbohydrates to meet the demand. Dawn phenomenon and Somogyi effect are two somewhat overlapping forms of morning hyperglycemia. They are both explained through their respective physiologic processes, and at least in my experience, there have been times when it's sometimes challenging to discriminate between one or the other. Dawn phenomenon involves morning fasting hyperglycemia, which is related to elevations of growth hormone at night. Growth hormone's kind of secondary effect is to raise blood glucose levels, and this probably makes intuitive sense. If we're telling our bodies to grow, then glucose is going to have to be utilized for that growth. Because growth hormone stimulates the release of glucose into the blood, the patient wakes up with morning fasting hyperglycemia. One important discriminating feature with regard to the dawn phenomenon is that these patients are not hypoglycemic in the middle of the night. This is not found in what's called the Somogyi effect. So you just had a little bit of a discriminating effect there. Dawn phenomenon, no nighttime or nocturnal hypoglycemia. Somogyi is a physiologic response to nocturnal hypoglycemia. During the night, the patient is mildly hypoglycemic. The hypoglycemia then stimulates a cascade of events that involve the liver in glycogen breakdown. It involves epinephrine, growth hormone, cortisol, and all of these things to essentially rebound the hypoglycemia to normo and even up further into hyperglycemia. This effect, the Somogyi effect, ultimately results in morning hyperglycemia. So here we have diabetic ketoacidosis in all of its pathology. It starts with hyperglycemia. Cells go into starvation mode. The liver is prompted to help. And ultimately what DKA leads to is the breakdown of muscle and fat because there isn't glucose entering cells. The breakdown of fats increases free fatty acid levels and certain acids called ketones, which is where this condition gets its name from, diabetic ketoacidosis. Ketones have a very particular scent about them when they're circulating through us in excessive amounts, and these patients will exhibit something very interesting called Kussmaul's respirations. Kussmaul's respirations are respirations that have a very fruity scent to them. The breath has a fruity odor to it. That's how it's described clinically. Okay, if you don't think it's that fruity when you're out in clinical practice, that's cool, no big deal. I'm just telling you kind of the way people think of it. So here we have a sequence of pathologies. Hyperglycemia raises osmotic pressure in the bloodstream. That leads to then this kind of drawing in effect of extravascular fluid into the intravascular space. That then leads to cellular dehydration and excess water in the blood, which leads to polyuria and polydipsia, which we've discussed. The excess water in the bloodstream can actually make a patient in DKA look as if they are hyponatremic or have a low blood sodium level. Technically, though, their blood sodium level is normal. It's just that there's excess water in the vasculature and it dilutes sodium. So what would a patient in diabetic ketoacidosis look like if they were coming to your clinic, or maybe you're working in the urgent care? Well, they would definitely have the three polys. The three polys always apply to a patient in hyperglycemia. But it is not, it's going to be an excessive amount of the three polys, and it's going to be accompanied by other stuff. For example, weakness, Kussmaul's respirations, systemic signs of illness like nausea and vomiting, ketonuria, the presence of ketones in the urine. And if their breath isn't fruity enough, their body odor may have a fruity scent to it as well. So that was a lot about DKA. What about type 2 diabetics in kind of their worst state? Hyperosmolar, hyperglycemic, non-ketotic syndrome or non-ketotic state. Well, this is all that is DKA minus the acidosis or the ketosis. And the reason why is that the presence of a small amount of insulin and a small amount of insulin sensitivity is enough to prevent the breakdown of fat and stop ketosis. No talk on diabetes mellitus and nursing care can ever be made without talking about the importance of foot care. Of the many complications from diabetic angiopathy, the peripheral neuropathy is significant. Peripheral neuropathy contributes to patients with diabetes mellitus having what are called silent MIs. They have myocardial infarctions, but there's no sensory nerves intact to say it. So it goes undiagnosed. Patients with peripheral neuropathy of the feet may stub their toe, break skin down below their feet in an area where you and I don't normally look, and that wound can get infected. But if a diabetic patient can't feel that wound infection, then the infection goes and grows. And the bacteria get in there and proliferate. Pretty soon, what was a small bit of foot trauma is now cellulitis. But again, the diabetic patient doesn't know. That cellulitis then is allowed to grow and grow and grow. That cellulitis goes into osteomyelitis. Now we've got a pretty big problem going on. That osteomyelitis may or may not respond to antibiotic therapy. Ultimately, the treatment for this may be amputation. If you're ever working with diabetic patients, and you're wondering why they had bilateral above the knee amputations, peripheral neuropathy, tissue infections, and osteomyelitis are probably a part of that clinical picture.